Today we are going to discuss about the different congenital anomalies of the urinary bladder. So the defects during the birth, the congenital anomalies of urinary bladder. So urinary bladder, it is basically the temporary storehouse of the urine. So it is a muscular reservoir of the urine, and it lies in the anterior part of the pelvic cavity, and it is composed of the detrusor muscle. So this is a temporary storehouse of urine. And talking about the size, shape and position, the size varies according to the amount of urine it contains. When the urinary bladder is empty, so it entirely lies in the pelvis, but as it fills with the urine, it expands and extends upwards into the abdominal cavity, and it reaches up to the umbilicus or even higher than that level when it fills, when it gets filled with the urine. So talking about the congenital anomalies of the urinary bladder, mainly we discuss about the bladder exstrophy and persistent urachus. The bladder exstrophy, also called the ectopia vesica, and the next one is the persistent urachus, and rarely we also find the congenital megacystis as the congenital anomalies of the urinary bladder. So talking about the bladder exstrophy, BE, or that is also known as the ectopia vesica, it is one of the common congenital anomalies of the urinary bladder. So it happens due to the complete ventral defect of the urogenital sinus and the overlying skeletal system. So the anterior wall of the bladder, it fails to develop. There is a big spherical or oval defect in the anterior abdominal wall below the umbilicus, and the mucosal edges fuse with the skin. The urine spurts onto the abdominal wall from the ureteric orifices. The pubic rami, is shown in the picture, are widely separated, and the pelvic ring loses its rigidity, right? And the rectus muscles, they are widely separated, and the epispadias is almost always associated with the bladder exstrophy. That is also called as exstrophy epispadias complex. So these are some of the features of the ectopia vesica or the bladder exstrophy. So talking about the incidence, the bladder exstrophy is more common in males than in females. So the ratio is the male 80% and the female 20%, 4:1. So basically the bladder exstrophy or the ectopia vesica, it is of two types. So the complete and the incomplete, right? The clinical features are the posterior wall of the urinary bladder protrudes through the defect. So because the anterior wall of the bladder is not formed along with the skeletals and musculatures of the anterior abdominal wall, so the posterior wall of the urinary bladder, it gets protrudes through the defect, and it is seen in deep red in color. The everted mucous membrane becomes ulcerated and painful. It may undergo metaplastic changes to form adenocarcinoma and bleeds rapidly. The efflux of urine can be seen from ureteric orifice, and when this mucous membrane is gently pulled upwards, the more pale wet trigon becomes visible. So these are some of the clinical features of the ectopia vesica, and we can find the different associated abnormalities along with the ectopia vesica or the bladder exstrophy. So relating to the pubic rami, the pubic rami are widely separated. There is absent pubis symphysis because the two pubic bones, they are not fused with each other, so there is absence of pubic symphysis. The pelvic ring is less rigid. The femurs are rotated externally, and the patient gets presented with the waddling gait, right? Because of the femurs are rotated externally. So talking about the umbilical associations along with the bladder exstrophy or the ectopia vesica, the umbilicus may be absent or there may be the presence of umbilical hernia. So talking about the genitalia in male, epispadias is almost always associated with the bladder exstrophy. The penis gets broader and shorter than the normal. The penis is drawn up and fixed to the abdominal wall. The scrotum is ill developed. The testis, the normal or they can be ectopic, or they can be mal-descended. The prostate and seminal vesicles are often rudimentary or absent. So talking about the genitals in female, we can find the cleft clitoris, the labia minora are found to be separated, and the uterus and vaginal anomalies can also be found as associated with the ectopia vesica. So the hernia, talking about the hernia, the umbilical hernia may be present, and bilateral inguinal hernia may be associated with undescended testes. So complications of the bladder dystrophy. The exposed vesical mucous membrane is usually ulcerated with hemorrhage, so it may become much painful. Hydronephrosis can be present due to the uterovesical obstruction. There can be recurrent ascending infections through the exposed ureteric opening. There can be metaplastic changes, and the half of the patients they die due to the renal failure. So half of the patients of the bladder dystrophy or the ectopia vesica, they die of the renal failure. And talking about the treatment is obviously the surgery, and in surgery we can do the diversion of urine into the colon or the ileal conduit, and excision of urinary bladder and closure. So, and a reconstruction of bladder and sphincter within first year of life. So within the first year of life, we can perform the reconstruction of bladder and the sphincter. So for this, the osteotomy of both iliac bones just lateral to the sacroiliac joints is done, and the urinary bladder is closed. The urethra is reconstructed behind the pubis, and the pubic bones are brought in the midline and fixed together. So these are the treatment principles of the bladder dystrophy, and there are certain complications of the treatment or the surgery. So they can be the infection, the stricture formation, mainly in the the ilio-ureteric anastomosis, right? And the recurrent pyelonephritis, hyperchloremic acidosis, incontinence, and renal failure. So regarding the urinary diversion, if the urine gets exposed to the GI tract, then we can go through the hyperchloremic acidosis. So this is all about the bladder dystrophy or the ectopia vesica. So the next congenital anomalies of the urinary bladder is the persistent urachus. So talking about the persistent urachus, firstly we have to remember about the allantois. Allantois, it is a structure that connects the umbilicus to the apex of the urinary bladder during the fetal life. So this allantois, it ultimately becomes the urachus. The urachus becomes obliterated, that is also known as the median umbilical ligament, and it extends from the apex of urinary bladder to the umbilicus. So regarding urachus, we can find these three main anomalies, that is the patent urachus, incomplete obliteration, and the urachal cyst. If both the ends are obliterated, if this is closed, this umbilical end is closed, and the bladder end is also closed, and in between it remains the patent, means in between there will be the formation of cyst. So regarding talking about the treatment of the patent urachus, as we already discussed, the main reason for being patent urachus exposed or found is the lower urinary tract obstruction. So if we manage the lower urinary tract obstruction, then this condition can be managed somehow, right? And if it cannot be managed, so ultimately we have to go for the excision of the umbilicus with excision of the urachus down to the apex of the urinary bladder. So up to the apex of the urinary bladder, we excise the umbilicus and excise the urachus, and we close the urinary bladder at the apex. So if there is failure of umbilical end to obliterate, so it gives rise to urachal sinus of the umbilicus, means the umbilical end is patent, means that is not obliterated or closed, means there can be the formation of sinus in the umbilicus, right? So through the sinus we can see the discharge of mucus through the umbilicus, and it often gets infected. And if there is failure of vesical end to obliterate, it does not produce any symptoms and remains unknown to the patient, right? So it remains as a diverticulum there. So And treatment of this incomplete obliteration is the excision of urachal remnant, right? That is known as the urachal cyst. So the middle portion remains patent. There is secretion of the patent portion forms cyst. The secretions that are secreted from the patent portion, they form cyst, and it may increase in size, right? So an immobile swelling in the midline in the hypogastrium deep to the umbilicus can be felt, right? If infected, that becomes painful and tender. Later on, adenocarcinoma may develop and stones may develop that can be identified by X-ray. So within the urachal cyst, stones may get developed. So its management is the excision of urachal cyst along with the remaining urachus and closure of apex of urinary bladder. And if adenocarcinoma has developed, so radical, we have to go for the radical resection, right? So this is all about the persistent urachus. So we have already talked about the two congenital anomalies, that is the bladder exostrophy or the ectopia vesica and the patent urachus, and the different forms of the patent urachus, right, we have learnt about. So the next one is the congenital megacystis. So congenital megacystis, it is infrequently occurring anomaly investigated during prenatal ultrasonography scanning, right? We can see we can diagnose it during the intrauterine life of the fetus, right? It is diagnosed in the prenatal USG scanning. So it gets complicated by associating with the GI disorders such as MMIHS, that is megacystis microcolon intestinal hypoperistalsis syndrome. And if it is isolated, that means the isolated congenital megacystis is the congenital megacystis without the GI complications, right? That can be isolated congenital megacystis or the congenital megacystis associated with the GI disorder. So it is the very rare entity, the congenital megacystis. Most commonly, the congenital anomalies of the urinary bladder that we find is the bladder exostrophy and the persistent urachus. This is all about the congenital anomalies of the urinary bladder.